I've been around for a while and I've seen a couple of trends during my long career in the medical field. On the one hand, and on the good hand, the science, the technology has gotten dramatically better. I mean, when I was an intern, if you came in with a heart attack, we basically put you to bed and let nature take care of it. Now you come in, you get an angioplasty, and you go home the next day good as new. So a lot of great things have happened that way. At the same time, the way care is delivered has gone to the pits. Medicine used to be a calling. It is becoming more and more of a business. And that is very, very distressing. To some degree, the trend was summed up. I took a picture of a Sunday Globe front page from a few weeks ago. I don't know how many of you are Globe readers, but you can see that 4 stories on the front page. There's one nice one about the Olympics, and then you've got the fact that drugstores are starting to go out of less affluent neighborhoods, leaving people with no way to get their medication. Of course, I think most of you are familiar with the Stewart debacle and how that's played out, not only in Massachusetts, but around the country, and there are others. And a final one talking about United Health, which has become the 800-pound gorilla in the healthcare field, having hospitals, doctors, insurance, PBMs, the whole works. They sort of run everything to maximize the dollars that they take out. This is a graph that I took from a New England Journal article a couple of years ago. And what they are doing is comparing the amount that is spent per capita on healthcare and life expectancy in the country. And there is, more or less a linear correlation. The more that you spend per capita on healthcare, the longer people live. We have one conspicuous outlier, good old US of A, where we spend dramatically more than anybody else, and our life expectancies are in line with Turkey and Estonia rather than our peer countries. So, when people tell you we've got the best health care in the world, don't believe it. We are a major, major outlier in terms of spending. We spend roughly 18% of our gross domestic product on healthcare, broadly defined. The average among peer countries, and I'll occasionally talk about OECD, which is Organization for Economic Cooperation and Development. That's basically Western Europe, Australia, Canada, US, Japan, South Korea, the developed countries of the world. And most of them spend about half or less of what we spend per capita, and their outcomes are better. For most of history, healthcare expenditures and the standard prices of everything tended to parallel. This is the cost index. This is, tells you what's been going to with inflation over the years, starting in 1960 and going out as far as 2016. And from all the preceding years through about 1980, healthcare expenditures and general expenditures were pretty much the same. Starting about in the mid-1980s, healthcare just took off like a rocket. A lot of factors going into that, but the major one is simply that we charge too much here. If we were absolutely the healthiest people on earth, you could justify we're a rich country, we can afford to spend the money, but in fact, we don't. There are 29 other countries in the world where a newborn has a life expectancy of 80 plus. Japan, Singapore, Switzerland, 83, 84. In this country, it's 7 years less than that, 76. There's a wonderful Time magazine cover story about a decade ago looking at Cuba, and one of the things they pointed out was that the average child born in Havana had a better life expectancy, better chance of living to age 2 than the baby born in the US. So a lot of things go into our health outcomes, and as I'll touch on later, it's not all the healthcare system. Some of it is habits. People will say, well, you can't compare the US with, Sweden. They're just a different group of people. The one thing that is clearly in the control of the healthcare system is maternal mortality. Women should not die from childbirth. And, something's always going to go wrong. You're never going to get that rate down to 0. Though New Zealand has it down below 2. Death rate per 100,000 live births, most of our comparable countries run between 6 and 9 per 100,000 live births. In the US, it's 24. Triple what it is in most of these other countries, and on a par with, third world countries. And that is unconscionable. The only area where the US leads is healthcare costs putting people into bankruptcy. When you talk to Europeans and you explain different systems, and everybody has gripes at their healthcare system. Nobody is fully satisfied with it. The Brits right now are quite upset with their National Health Service, which has been starved, and as a result you're seeing increased waits and a lot of other things. But none of them would want to trade with the US for the simple reason that in this country, if you don't have good insurance and money, you're in trouble. We have, it's the leading cause of people going into debt, showing up on their credit reports, which in turn means it's harder for them to buy a house, buy a car. And a lot of people, unfortunately, delay getting needed health care because of medical debt. This is a terrible slide, but I took a picture of it out of a newspaper. It says Kaiser Family Health, who do a lot of, if you're interested in delving into the details and the nuts and bolts of this, the Kaiser Family Foundation does some great stuff on healthcare. And if you go to their website, you can find more than you really want to know. But the first question is that people who did not go to see a doctor when they thought they should because of cost. Half of all people, 2/3 of people who already had medical debt on their record. So, and you get people who didn't pick up a medicine. Again, 1/3 of everybody went to the drugstore, were told the price, got sticker shock, and left without it. And if you happen to have medical debt already on your system, it was over half. People who I've had patients who, when they found out what something was going to cost them, would say, well, I've only been taking it every other day, because that way it could stretch longer. So it is not only, an impact on your income and your other style of living, but it has major adverse health effects. Okay, do we simply use too much medical care? No. In Europe, the average person goes to see a doctor 6 to 7 times a year. In the US, it's 4. So the Europeans actually use more health care. Hospital discharge, a little bit more. They have maybe 25% more hospital stays than we do. So they are not using less health care, they're simply paying less for it. One could argue, well, the population is getting older. It's true. Nobody in this room is, but otherwise everybody is. And as we get older, we need more health care. But again, that is true in Europe, it's true in Japan, it's true in Korea, it's true everywhere. The world is getting older and their costs are not going up the way ours are. A friend of mine was in France, had what he was sure was a herniated disc, walked into an imaging center, asked for a CAT scan of his back, and cost him roughly, when you translated from euros to dollars, about $200. Median price in this country is $1,450. Same equipment, nothing different, 7 times as much. Another unfortunate friend of ours was in Paris, fell down a flight of stairs, broke her hip, went to one of the top hospitals in Paris, had a hip replacement, where, among other things, the food was much better than it is here. The cost for her procedure, including having physical therapists come to their hotel room until she was able to travel, was $8,200. Median price at that time for hip replacement in this country was $3,800. So, when she came back, saw the doctor here, yeah, looks great, wonderful, good, everything was the same except for the price. All right, why are we so expensive? There are a lot of reasons. One of them is that we have a remarkable administrative overhead added to our nominal healthcare costs. Roughly 25% of the $4 trillion that's spent is going not to help anybody feel better, but simply to push paper. About half of that 25% is the health insurance companies, who are very profitable, thank you, and the other half goes to the costs of hospitals and doctors complying with the mandates. Out of this, I thought, was a very telling detail. Duke University Hospital has 1,500 billing clerks. Montreal General, which is a comparable sized teaching hospital in Montreal, has 10. So, these 1,500 people are not helping anybody feel better. They are not coming to clean you up or tidy the room. They're just simply sitting in a large office generating paper. Ma'am?
How do they justify the 1,500 billing?
Oh, they need them. That's because they have to, they're like Montreal General's a referral hospital from all over the world, so is Duke, and they generate lots of bills to lots of different insurance companies, and they claim they need them.
But somebody's got to be watching over all this infrastructure.
Healthcare is one of the few activities where there is no increased efficiency as you get bigger. People talk of economies of scale, that if you make your widget factory 3 times as big, you'll be able to turn out more widgets without increasing your costs as much, and you'll make more money per widget. Healthcare ultimately comes down to a doctor and or a nurse with a patient, and you cannot automate that. What happens is that as the organizations get larger and larger, you get more and more layers of administration. One of my earliest practice sites was out at the Memorial Hospital in Worcester, and the CEO suite consisted of a hospital administrator, a chief financial officer, and a director of nurses. And the 3 of them, that was the so-called C-suite. And you go to Mass General Brigham, well, now you've got the head of the overall organization, who makes about $6 million a year and has a whole flock of people under her. Then at each of the constituent hospitals, you have a CEO, a president, an assistant for this, a vice president for that. So, you have got a C-suite that may have, 50 people in it, as opposed to 3. And, all, as I say, get larger and larger hospitals mean larger and larger administrative staffs, and they simply do not, add anything to patient care. If you've ever looked at a hospital bill, the markups on everything. Every time somebody gives you an aspirin, there's a $5 charge on your bill. There was a fascinating little newspaper piece that somebody who had a hip replacement saw that on his bill, the actual piece of metal that went in was charged out at $2,600. And he spent a large amount of time and effort and finally tracked down what the hospital paid for it, and it was $1,500. So, when you're in a sizable city like Boston, New York, Chicago, anywhere, you have many, many hospitals, all of which are competing with each other, all of which want to do everything. So that instead of having one hospital that gets really good at some complicated procedure, you have 6, 7, 8 hospitals all spreading the number of cases among them. So the care isn't as good, but everybody has to gear up for it. Everybody has to have the equipment, everybody has to have the specialized nursing. So again, it doesn't improve care, but every hospital can say, well, we can do everything. An unfortunate trend, which I don't think is going to be reversed, is that as the administrative burden of practicing medicine gets worse and worse, more and more doctors are going to work for large organizations. The norm when I started in practice was, doctor was an independent contractor. Maybe 4 or 5 of them would band together, work together, or you'd be 1 or 2. That essentially no longer exists. A decade ago, about 25% of physicians were hospital employed, and a couple of years ago, 3/4. And it's gone up. I think it's about 80% now. So doctors are no longer independent. They're working for organizations. And the one consistent thing that happens is that the cost goes up. If you are Dr. X in an office building and you have your name on the door, and you're a cardiologist, as I am, you do an echocardiogram and you get paid $800 for doing it. I sell my practice to the hospital and it now says XYZ General Hospital, Dr. Hoffer's office, and they do the billing for me. That same echocardiogram, same technician, same equipment is now billed out at almost $2,000 because you've got a hospital fee added to the doctor's bill. Having fewer hospitals in an area gives you the old monopoly factor that, if you have fewer than 4 hospitals in a community, then prices are invariably higher because there's absolutely no incentive to compete on price. Emergency departments, a lot of problems, one of which is simply that, I don't think it's a great place to get care unless it's a true emergency. If you're throwing up blood or you've got crushing chest pain, yes, get yourself by 911 to the emergency room. But if you have a cough or a bad back or you think you have a urinary infection, the emergency department is not where you belong. You're going to end up getting a lot more tests than you need because these people they don't know you. They're going to, do lots and lots of tests. Bills routinely inflated. The the electronic medical record, which is now ubiquitous, has been very, very good at allowing people to game the system and charge too much. Personal example, one of my sons developed pneumothorax, air outside the lung. I called a thoracic surgeon I knew, said, bring him into the emergency room. I'll meet him there, take care of him. We did that. He did absolutely everything. At one point, one of the emergency doctors poked his head in and said, hey, how are you feeling? My son said, okay, a little sore. Oh, I'll get you some pain medicine. That was the total interaction. We later saw a bill for a comprehensive emergency department evaluation. Pretty comprehensive. How are you feeling? So And this is, again, it's very easy with an electronic record to push a couple of buttons and populate an entire record, even if you didn't do anything. Is it fraud? Yeah, it is. But it is frequently done. Another problem is that, and I don't know if you followed any of the fuss about surprise billing that sort of been dealt with in Congress, but you go to a hospital you know is in your insurance network. You're careful, you're compulsive, you check that. And indeed, the hospital is. But then you discover that the emergency physician opted out because they know darn well you're not going to choose your emergency physician. You go in and you see whoever is there. So they found they can make a lot more money by simply not taking insurance and charging whatever they think they can get away with. This is what happened to emergency department billing. The bottom two lines are physician offices and urgent care centers, and these are emergency department facility fees and physician fees, and you can see they just skyrocketed. And again, if you're in an emergency, you don't stop carefully, take out your little book and pick where you're going to go. A problem that actually I could spend an hour on, I've written a couple of papers on, is a good functioning healthcare system should have roughly 50% primary care doctors and 50% specialists globally. Most primary care doctors can handle most problems. Obviously not all. You need a hip replaced, your family doctor isn't going to do that. You need a heart catheterization, they're not going to do that. But the large majority of the things that we're all prone to are well handled by a good primary care doctor. Unfortunately, in this, primary care doctors are so underpaid compared to specialists that fewer and fewer graduating students are doing primary care. They'd all rather be dermatologists or something else where you can work fewer hours and make more money. So, what happens is you go to a specialist and you have a procedure done. And procedures are very, very well paid. The amount that you get that a doctor can bill or can get paid for is determined by a somewhat secretive committee, which was run under the AMA, that they all sit around a table and they decide how much any given thing, whether it's a level 2 office visit or an upper endoscopy or a gallbladder removal, how much it's going to get paid. And since about 85% of the members of this committee are specialists, you scratch my back, I'll scratch yours, and of course that procedure is really demanding and takes a lot of time and it'll be well paid. So, historically, a doctor spends time with you, listens to you, examines you, counsels you, gets paid a lot less than somebody who sticks a tube somewhere, even if the sticking the tube in takes less time than a proper clinical evaluation. So you go into a good primary care doctor and you say, I've been having heartburn for a couple of weeks. And the doctor examines you, asks about a few of the warning things that might suggest a serious problem, and says, okay, you've got a little acid reflux. I'll give you an antacid pill, take it for a month, and if you're not all better, then we'll look a little further. You take the same complaint to a gastroenterologist. The gastroenterologist, well, you've probably got acid reflux. I'm going to take a look down there to be sure. So he puts the scope down, and after you come out of the anesthesia, says, yep, you have acid reflux, take this pill, and in a month you should feel a lot better. Same result, same treatment, but in the one case you have an office visit, and the other you have a multi-thousand-dollar bill from hospital and specialist. Pharmaceuticals, another one where again, we could spend an hour and we'd all get very frustrated and angry, and there is a little bit of a chip in this hopefully happening, I think. But again, we pay roughly twice as much annually for medications than people in comparable countries. I pulled these numbers out a few years ago. They're higher, but the relative amounts haven't really changed, which is for this commonly used blood thinner, US price about 4 times what you get in pay in Canada, EpiPen 3 times, a commonly used form of insulin almost 4 times, cholesterol lowering drug 5 times as much. Again, same drugs, exactly the same drugs, same package, same company, same everything. The only thing that's different is price. You know, I don't know if you're familiar with Mark Cuban's Cost Plus Pharmacy. If you don't have good insurance for medication, I would encourage you to take a look at it. Mark Cuban is an entrepreneur. He's not in this business for charity. He's in it to make money, and at the same time, he's doing a lot of good. And they charge what the pills cost them, plus a pharmacist fee, plus a flat amount for delivery. And so they're making money, but you, in fact, are saving a ton in many cases. Doxycycline, an antibiotic, if you happen to be unlucky enough to get the tick bite and get Lyme, doxycycline is what you take. If you go into the average pharmacy, $800 for a course of treatment. You can get it from him for 16 bucks. And he's making money. So imagine the amount of money that's being made there. And up and down, I don't think we need to go over all of them. But, you know, Medicare Part D could have saved $3.6 billion if they had bought their generic drugs from the Cost Plus Pharmacy instead of the retail.
How do they justify the pharmaceutical companies these tremendous expensive drugs? Because
They will tell you
yeah,
that they need this money to support their R&D. And the problem with that argument is that they spend significantly more on marketing than they do on R&D. Number two, people who have looked at the objectively, and it's sometimes hard to get the numbers from them, but in fact they overestimate their R&D costs by about a factor of 3. The American consumer is paying the price for same drugs. Hey, if you look at what people are paying in Canada. These are all specifically picked as these are all brand name drugs. And again, they're not losing money on the products they sell in Canada,
no.
or they wouldn't sell them. What they are doing is just ripping off the American consumer. I'm not going to give you a whole litany of horror stories. I'll just give you one. I don't know if any of you with the name Martin Shkreli is familiar, the pharma bro. Toxoplasmosis is an uncommon infection. Tends to hit people with immune deficiency, some pregnant women. Untreated, it's lethal. And there's only one treatment for it. The drug brand name is Daraprim. And Martin Shkreli bought the company that was making Daraprim, and he raised the price from $13 a pill to $750 a pill. Nobody else was making it because, again, this is an uncommon illness. There wasn't a whole lot of demand for the drug, maybe a few thousand cases a year. And people knew that if they went into competition, he'd just lower the price until they got out of there. So, he was brought before Congress. He was unapologetic. Fortunately, he ended up going to jail for stock manipulation, but not for this, which he should have. And even more disturbing is some years after this all took place, somebody was interviewing an entrepreneur. What do you think of Martin Shkreli? Oh, he was doing what he should. He's got to get the most for his shareholders. You know, the public be damned. The other wonderful thing the pharmaceutical industry does is try to increase demand for their products. There are only 2 countries in the whole world that allow direct-to-consumer drug advertising, New Zealand and us. And you've seen these ads, you know, they're sort of stereotypical. You start off with usually a black and white of somebody who's really unhappy and miserable and isolated from their family. And then the magic medicine comes in and you switch like, you know, Dorothy and the Wizard of Oz to full Technicolor and everybody's smiling and happy. And then rapidly as possible at the end, you get a whole list of side effects that, you know, you can't pay any attention to. But they work. They go into doctors' offices and, you know, bring a free lunch and tell the doctor about all the wonderful medicines their company makes. Most doctors, almost every doctor will say, oh, I can't be influenced by, you know, somebody bringing lunch to the office. Well, the pharmaceutical companies are not dumb. Greedy, yes, dumb, no. And there are very good studies that you can actually show a linear graph between the numbers of meals and the prescriptions written. They may not be doing it consciously. It may simply be, oh, that really nice detailed person, you know, their company must be pretty good because they're so friendly. But you know, the more visits you have, the more free lunches, the more you prescribe. Opinion leaders, people who give lectures, people who write guidelines that doctors are supposed to follow, frequently are getting well paid by the pharmaceutical company, either to give lectures or to support their research labs. And again, you know, you don't bite the hand that feeds you. A lot of these people are favorably disposed towards the company. If you look at a prescription bottle or of anything, there's an expiration date, ignore it. There's absolutely no reason to throw out a pill unless it is crumbled or it's the Army, which is, you know, kind of wanted to make sure they had enough medications in case of disaster, took a whole bunch of prescription medications, put them in a box, buried the box 10 feet underground, and dug it up 10 years later. And virtually all of the pills were still perfectly fine. So, you know, most of these expiration dates can be quite safely ignored. Don't throw out those expensive pills. Pharmacy benefit managers, again, only in America. We are literally the only country where this industry has taken foot. These are people who claim to be able to negotiate better prices for drugs, save everybody lots of money. And in fact, what they do is they skim a lot off the top. One fascinating example of why there's sort of a perverse incentive is Humira is a very well-known drug used to treat rheumatoid arthritis, among other things. And Amgen came out with a biosimilar. It's not quite a generic, it's a slight tweak, but it does the same thing to compete. Because Humira was charging $90,000 a year, sounded like a good market. And Amgen's product is, you can buy it at one of two prices, either $85,000 a year or $40,000 a year. Seemed kind of, why would anybody pay $85,000 when they could pay $40,000? Well, the PBMs, in fact, they take the $85,000 price, they negotiate it down to $70,000, and then pocket half of the so-called savings. So it's a wonderful business if you can get into it. Another drug problem, which I don't have a good answer for, but what we need to think about, is that we are moving into the era of miracle cures. cures for genetic diseases, cures for diseases that had never been able to be treated before. And this caught my eye because, in fact, there are drugs that will treat things that, as I say, 5 years ago, 10 years ago, had no treatment whatsoever. You either suffered with it or you died with it, and all people could do is try to help your symptoms. Now you can go in and change the genes and cure them, we hope. And these are all extremely, extremely expensive. One of the problems that we have is the track record on these is all pretty short. They've only been out for a year or two. And you're talking about something, if you give it to a child, you may be looking at, are you actually curing them? Are they going to now live 70 years when they would have not made it past 25? We hope so. And so far it seems pretty good, but who should pay for it? If the insurance company is going to say, these people are only with us for an average of 2.4 years and then their employer changes insurance, so why should we be on the hook for $1 million drug when it's, somebody else is going to benefit from it? So I think this is something, one obvious way is, okay, you claim this miracle drug is going to keep this child alive for 70 years, split the $1 million, divide it by 70, and let whoever is insuring them at that year pay that year's freight. And that way, if it turns out that after 5 or 6 years it stops working, you're not on the hook for the $1 million, $2 million. So, this is more of an ethical problem. This is one where some small companies have in fact done miraculous things, but we don't know how we're going to pay for it. Another topic I'm going to just touch on very briefly, I've spent an hour on it for professional audiences, but misdiagnosis is an under-recognized problem. There was a report that came out several years ago from the National Academy of Medicine, and they concluded that 5% of adults seeking outpatient care are misdiagnosed across the board.
Sorry, what year was that study? What year was the 5% from?
That is year in, year out. That's every year.
I think after COVID, it's way higher. I'm a nurse. I'm just saying, I deal with it on an everyday basis. I'm going to say that's higher.
Yeah, we're talking across the board,
Yeah.
10 years ago, this year, and it has not really fallen. It's something, but their conclusion was that literally every one of us, either directly or with an immediate family member, was going to have a misdiagnosis. Again, this shouldn't be news. Autopsy studies going back 100 years have shown that about 10% of hospital deaths are caused in large part by a diagnosis that was missed. Yep.
Have any studies been done with second opinions?
I'll come to that. Problem, there are a lot of reasons for it. Sometimes it's the patient's fault. They're embarrassed, they don't want to tell, they don't give a full story. Sometimes the doctor either omits or misses an important physical finding. Lab tests are misinterpreted, x-rays. One of my other kids, I have an unlucky family, one of my sons went in to Toby Hospital for a chest x-ray for a cough. It was read as clear lungs, normal heart. And 6 months later, when he still had a cough, he went to see a pulmonary guy I know who said, "You had an x-ray, bring it with you." And examined them and looked at the x-ray, and he said, "Good news is your cough is a postnasal drip. I'll fix it with some pills. Bad news is that isn't a normal chest x-ray." He had very enlarged lymph nodes in his chest, turned out to have Hodgkin's disease. And the diagnosis was delayed 6 months because the radiologist just missed it. Commonest reason a diagnosis is missed is that the doctor or nurse practitioner or PA simply never thought of it. If you don't think of a diagnosis, you are not going to make it. And this is, an area I've spent most of my career on, is working on decision support, trying to help doctors make more accurate diagnoses, trying to make sure that everybody has at least reasonable number of diseases to think about instead of the first one that comes to their mind. Well, so everybody doesn't just sit back and say, well, it's all the hospitals and doctors' fault. We have to take a little bit of the blame ourselves. If you do everything right, and this was an excellent study that came out about 6 years ago, that if you do 5 good things, you have a good, decent diet, you don't smoke, you don't drink to excess, you exercise regularly, and you keep your weight down. And the more of these things you do, the longer you're going to live. 50-year-old woman who scored 5 out of 5 lived 14 years longer on average than one who was 0. 50-year-old man, 12 years longer. So, we have to take some responsibility for our health and not just expect the system to fix things. And of course, what do I have to say about guns? It's one of the very few countries in the world where you have to train your kids what to do if an active shooter comes into the school. And we've got to get those, it's not mental health, it's the damn guns. If somebody has got mental health issues and they take a swing at you, they're not going to kill you and 6 of your neighbors. If they have an AK-47, they will. We've got to get those off the other people's hands. We've got to be much more proactive dealing with the opioid epidemic, which has skyrocketed since COVID. We've got to drive better. We've got to get some of our very large cars downsized. You may be safer driving a giant SUV than somebody in a small sedan, but the person in the small sedan is going to pay the price. How would I fix it if I was the czar and I could do anything I wanted? I think Bernie Sanders was right. Medicare for all would, in theory, be optimal. Affordable Care Act, so-called Obamacare, definitely has some things that are good. It's hard to argue with the fact that insurers can no longer refuse to cover pre-existing conditions, or say that once you've hit $1 million for your metastatic cancer, sorry, you're on your own. Those are gone, and that's good. Keeping your school-age children on your insurance a little longer is good, but it tinkered. It did not. The reason it was able to pass is the insurance companies loved it, more customers, hospitals loved it, more paying customers, doctors liked it, more paying customers. So nobody's ox was really gored. Prices didn't come down. Single payer could give everybody basic health care coverage. You want more? Sure. Even in Canada, which has universal government paid insurance, if you say, well, if I'm in the hospital, I want a private room, you can buy an insurance policy for that. You want, a policy that covers, cosmetic surgery, fine, buy it. Those are not basic healthcare needs. But nobody in this country should die because they can't afford their insulin or because they're afraid to go to the hospital when they have appendicitis. And that's, I think, basic healthcare is a basic human right and should be available to everybody. Single payer would be much more cost effective. The 25% of our total so-called healthcare dollar goes to administrative expenses. The insurance companies charge roughly 12% to administer paying bills. Medicare charges 2%. And so, if you could get that 12% down to 2% and you did nothing else, you'd cut our bill by 10%. Some of the absurd overpricing could be brought into. A lot of procedures that are complicated when they start get to be more and more routine, but the prices never come down. when people first started doing colonoscopies, there was an art to it. It took a lot of training. It was nowadays, Leahy Clinic usually uses PAs to do routine colonoscopies. That's how easy they think it is, and yet the price is still priced as if this was a really complex, difficult new procedure.
I have a question. If a PA does your colonoscopy,
It gets charged by the Department of Gastroenterology. Doesn't cost less. You don't save any money.
between who does it? I mean, the lady who empties the trash.
They seem to have, it is such a routine procedure for the average person that you don't need complex skills. All right, realistically, what are we going to get done? And in this country, our federal government is so polarized and so dysfunctional. I'm not optimistic on anything. At the federal level, it would be nice to see a very slow expansion of Medicare. Maybe drop the age from 65 to 64, and a couple of years later, drop it to 63. Allow small employers to opt into Medicare for their employees. The small employer is at a real disadvantage. If you're General Motors or you are a very large company with thousands and thousands of employees, you have people who are competing to get your business, and you can kind of pick and choose which of the health insurers you want to deal with. If you've got 12 employees, you're lucky if you find anybody who'll even sell it to you. And if you do, it's going to be significantly more per person than the large companies pay. And so, letting...
I was even going to say, to advocate, like, my thing is so I'm a nurse. I have a ton of nurses who work 55 to 65 just to cover their health insurance.
Yeah.
If they allowed 55 and up to buy into Medicare, let us buy into it, right? Because there's a lot of LLCs, there's a lot of single, people out there have their own companies. I don't want to buy in the open market. And to be honest, it would allow people to work less hours instead of being full time, and we'd have health insurance. It would actually, like, when you talk about cost effectiveness for nurses who are at the top of the pay scale, they knock back their hours. They're not full time anymore. They hire 2 more nurses to fill that gap. There's a lot to it. I disagree with some of what you're saying here, but I really do think Medicare, if they would allow me to buy in at 55,
Yep.
I don't need it to be free. I want to just buy into it.
Absolutely, and you'd be a better deal for Medicare too, because you probably have lower costs than somebody who's 75.
I'd be cheaper, and I'd be paying into it.
Okay. A lot more can be done at the state level, and this is where I think all of us in the room may have a little more influence. It's very unlikely that you've ever gotten up close and personal with Elizabeth Warren, but it's much more likely that you have with your local state rep or senator. These are people who come to the fairs and come to meetings and sit down and talk to them. One of the things that California just passed recently is a bill that is giving the Attorney General there the ability to block venture capital takeovers above a certain size. And we should have that here. I mean, Stewart should never have been allowed to happen. We should have laws on the books that lets the state government have oversight and ability to refuse that kind of takeover. When you get hospitals merging, invariably what happens is the prices go up. Care doesn't get any better. So we need to have better oversight of that. Change is possible. I mean, I hate to think that I'm just tilting at windmills all the time, but things can change. I mean, when I was a teenager and I went on a road trip with my family down south, this was from Montreal, I grew up in Canada. As soon as we crossed the Mason-Dixon line and stopped at a rest stop, I saw bathrooms that said white only, colored only. I mean, this was quite something to a 13-year-old from Canada. While we're far from perfect in race relations, we don't have that anymore. Single-sex marriage was illegal. now it's accepted and legal. So the society can change if there is enough demand, and I think we have to push it. All right, practical things you can take home with you. There are ways to lower your costs. Number one, if you're prescribed a brand name drug, you should always ask your doctor if there is a generic equivalent, which will immediately save you a fair amount of money. Go on to Cost Plus Pharmacy website, or even look at GoodRx, which will give you coupons too. But there are lots of ways you can save money. Simple thing, when the size of a pill doubles, the price doesn't usually double. So if you're taking 5 milligrams a day of something, get 10 milligram pills and split them, and that'll usually save you a significant amount of money. We all know we're going to use the internet, and nobody's going to stop you using the internet to look up your healthcare questions, especially some of the newer large language models, things like ChatGPT, really aren't bad. But again, don't Google it, because when the results come back from Google, typically you're going to see the paid placements up at the top. So go to nih.gov, go to all of the major teaching hospitals have websites, and yes, they're partly marketing, they want you to come there. But if you go to a mayoclinic.org, you're going to get answers to a lot of questions that are scientifically valid and not simply put there for marketing. When you go for a medical visit, it is very important, especially these days when the visits seem to be getting shorter and shorter and shorter, to go in prepared. The worst thing you can do is you go in for your semi-annual check of your blood pressure and your diabetes, and they're fine. And then as the doctor's got their hand on the door, you say, oh, I've been having this chest pain. Immediately the doctor has either a choice of either I'm going to be late the rest of the day, or I'll ignore it, or I'll have to ask them to come back. So if you have a new important problem, bring it up first. Say, Doc, I know I'm here to get my diabetes checked, but can I tell you about this chest pain? So don't,
Write your questions down.
Yeah, and they say, bring notes and take notes. Have everything written down so in the flurry of the moment you don't, forget the important things. It has been well documented that by the time you get from the office door to your car, 2/3 of what the doctor told you, you've forgotten already. So take notes, write down.
But why can't they have, like they used to, where you go into the doctor's office and sit down, he's at his desk, and you're sitting down calmly talking to him, and then you go to the examining room. That's the way they do it in Spain, where I was part of the...
That's the way I always did it. But people more and more are pushed. You've got 15 minutes. And in that 15 minutes, not only do you have to deal with what the patient is bringing to you, but you've got to go through this checklist of stuff pushed by the electronic medical record. I mean, I had a record which would not let me close a note unless I certified whether the patient smoked or not. These were people who, I had known them for 30 years. They hadn't smoked yet. I didn't think I really needed to ask them whether you started smoking. But I couldn't close out the record without it. So you've got people who've got a short time, a lot of demands, administrative demands, and so, go in prepared with your priority, have it written down, take notes on what's said. Doctors tend to speak, and not as many, but nurses too, in medicalese, things that make sense to them, but may not to you. You get into using a jargon. And so you want to, if you don't understand, it's okay to say, would you mind saying that again in English? Or say, I think what I'm hearing you saying is X, Y, Z. Is that what you're saying?
The child or whatever. And I mean, I remember, I was at an appointment with my mother and they're like, well, we can't have you on the phone because of HIPAA. I'm like, okay, she made the phone call. She's the one who wants me here. There's no HIPAA violation. So
Yep.
I'm gonna stay on the phone.
Or bring somebody with you.
Right, and
Have somebody.
But I mean, I couldn't be there, and they literally said to her, "Do you have any allergies?" My mother said no, and I said, "Of course she has allergies." You know, they're like,
Yep.
"Oh, you can talk now."
Did your mother give permission for you to?
She made the phone call. It was her phone.
Yeah,
You know,
her phone.
But did you tell the other person?
Yeah, but she doesn't have to because it's her phone and she made the phone call. So that's automatically permission, but
The only dumb question is the question you should have asked but didn't. So do not ever be afraid to ask a question. Somebody brought up the issue of second opinions. Second opinions, particularly for serious diseases or diseases where a major form of therapy is being, should always have a second opinion. You know, if somebody says that, you know, you've got a strep throat, no, you don't need to go for a second opinion. Somebody says, you know, you have cancer, yeah, you do. Somebody says you've got, you know, severe coronary disease and we should do, you know, a cath and an angioplasty. Yes, you should get another opinion before you do it. Second opinion, Mayo Clinic, which sees a lot of people for second opinions, found that in roughly 20% of people who came to them for a second opinion, there was a major change in diagnosis. Minor nuances in about another half. In about a third of them, they said, no, your doctor was absolutely right, we do the same thing. But, you know, about a quarter of them, it was, you know, there was complete change. So never be afraid to ask for a second opinion.
and your doctor should be open. Should be.
If your doctor is offended by that,
Yes.
change doctors.
That's right.
A good doctor should never be offended by that. As we get older, we have to think about end-of-life care. Everybody should have an advance directive, something you do when you're in good health that can be referred to when you're not, and should be discussed with your family when you are in good health, not when you're in the hospital on a respirator and then they're trying to decide whether to leave you on it or not. So have it in writing, have everybody on the same page.